So yeah, if you read the ACCHA guidelines on heart failure are hundreds of pages long, and you can really boil it down into these 16 points. And I'm going to go through these quickly just to kind of give you a sense of what's in them. But we're going to dive back and kind of look at some of what's new here. So clearly, today in patients with newly diagnosed stage C heart failure, where we are is, we're beta blockers and we're RAS drugs in any order. Often people ask, which order should you use? And oftentimes it's easier to start the RAS drug first because patients feel better immediately, as opposed to beta blockers takes a while. And I'm going to point you today that the ARNIs are really the preferred drug. We'll point at the end to that really the key is that each agent has to be pushed up to maximally tolerated dose. That's something we don't do really as well as we should. And then the point here is beta blockers are generally better tolerated when patients are already dry. They're already have a good volume status, whereas ACE ARBs can be used when patients are wet and decompensated. That's why often in the hospital we focus on the RAS drugs first. Really only guideline recommended beta blockers should be used, and I'm going to show you that I really think that means today that carvedilol is your heart failure beta blocker. We don't use much Metoprolol, but if you compare carvedilol to Metoprolol, I'd like to show you what's some data there. And among the angiotensin agonists, ARNIs are preferred. So if you're still using ACEs or perpetuating ACEs or ARBs, I want to teach you how to change that prescribing behavior and to switch to the newer agents. Diuretics are really only as needed to achieve decongestion, and it's a myth that people in heart failure need a diuretic. Now, sometimes after recent decompensation, diuretics can be useful, but in the long term, your method of managing sodium and volume is to restrict volume and restrict sodium. And that works in most cases. The best approach beyond that is to simply have patients take their weights and flexibly dose diuretics according to dry weights. Aldosterone antagonists, 0.4, mineralocorticoid receptor antagonists are useful. The key thing there is that really above creatinine of 2 or 2.2, you're going to avoid those drugs because of concern for hyperkalemia. There is some evidence that when used with the ARNIs, there's an actually additional dose margin of safety for the MRAs, the mineralocorticoid receptor antagonists. Isodil 0.5 is useful in African American patients, Black patients, if they have persistent symptoms or they don't tolerate RAS drugs, but in general, RAS drugs should be used there. And then the ideal time to consider optimization is during hospitalization for HFrEF. A lot of times we hear, oh, they'll start that as an outpatient. Oh, they'll start that as an outpatient. And that is actually, as we're seeing now, is that because of risk for readmission is really clustered after an admission, we want to move these new therapies into the hospital. So in the past, it was get them dry, keep them on what they were on, get them back out, they'll fix it up. Now it's do this in the hospital, as I'll share with you, and I'll show you some of our own data on that. Mitral regurgitation is interesting, and you need to look for mitral regurgitation when you do cardiac ultrasounds, because that can be an opportunity to, now what we know is to clip or close off the mitral valve, even in functional MR resulting from heart failure, as long as certain criteria are met. And so there's a new attention on mitral regurgitation as a contributor to heart failure now that there are percutaneous therapies, both for primary valve dysfunction as well as for functional MR due to heart failure. So if you see more than moderate MR, you should be getting in touch with cardiology, as maybe that's an opportunity. Point 8, the one thing that challenges us is hyperkalemia. And I think if there's going to be one thing you're going to be doing as an outpatient, it's monitoring lights, particularly on RAS drugs. But as I mentioned too, the mineralocorticoid receptor antagonists and ARNI drugs are better tolerated together in terms of hyperkalemia. Of course, point 9 is a key one, socioeconomic barriers to some of these newer therapies. I will tell you that the ARNIs and the SGLT2s are widely covered by payers. Why? Because they know that if you put a patient on these drugs, the patients do better very quickly, and there's payoff to them and to the patient. But if you have a question in the hospital, use social work to check affordability, make sure it's consistent with their plan. But 3/4 of plans provide rnas with no prior authorization and for $40 or less a month in copays, for example. Sometimes patients will recover EF. Their EF will get back to 40. We always continue. We always tend to continue the therapies, and when you have recoverable LVEF, we tend to continue therapies. There's about a third that will relapse into low EF if you stop the drugs. Repeat cardiac ultrasounds are not needed, but when there's a change of status, a cardiac ultrasound is okay. You should be careful with repeat ultrasounds, though, because they often yield little useful information. Only 1 in 10 will yield information. I'm going to point you today to the use of serial BNP levels, as a way to assess adequacy of decongestion. One nuance there is that, and I'll talk about this when I talk about the rnas, is that the rnas may impact in the short term BNP levels because they inhibit neprilysin, which is what breaks down BNP. You have the ability here at Georgetown to use right heart catheterizations. And when do you use those? You use when people have persistent symptoms despite good diuresing, creatinine's moving in the wrong direction despite they still look congested. Those are times the right heart cath is useful when there's uncertainty in the hemodynamics. Certainly, we're fortunate in our system on point 13 to have advanced heart failure specialists, which anytime a patient has class C progressive symptoms, gets admitted with class 4, that's a patient may be moving towards advanced heart failure requirements, and it is reasonable to refer them for consideration of even advanced therapies besides just drug therapy in stage C. It certainly takes a team. You get that when you push into advanced heart failure as a consult. And key for us is to assess medication adherence. A key reason medication adherence is directly tied to outcomes. The better patients adhere to drugs, the better they do. All right, so let's get into some of the data. That's an overview of what's in the therapy, sort of heart failure, soup to nuts, in these 16 points in the new guide, what's new in the guidelines. But let me take you through some of the background. We all know, and everybody knows, the big 3 drugs in heart failure are RAS drugs, beta blockers, and mineralocorticoid receptor antagonists. And even in advanced class heart failure, so these are data from class 4 heart failure with ACE inhibitors in the top, beta blockers in the middle, and mineralocorticoid receptor antagonists in the bottom. I was a senior medical student when Consensus 1 came out. Consensus 1 was a randomized trial of enalapril versus placebo in advanced class 4 heart failure, and there was striking reductions of mortality at 6 months. This is pre the beta blocker era. This is pre the spironolactone era, and this really changed therapy forever in heart failure. It was a mortality play with early payoff. From there, the data went then to establish lower and lower classes of heart failure benefiting from RAS drugs, the addition of ARBs as an alternative that's equivalent, and that's where we are today. How about beta blockers? What beta blocker do beta blockers work in advanced class heart failure? Gosh, in the early 90s, it was, you would never use a beta blocker in heart failure. That's a compensatory mechanism, sympathetic tone. But in fact, sympathetic tone is important in the short term, it's deleterious in the long term. And so beta blockers, as we all know, are standard therapy. And why? Because it's a mortality play. Copernicus is a study of carvedilol, titrated at 25 milligrams, BID, I'm sorry about that, in class 3 and 4 heart failure, with mortality reductions of 35% in 10 months. This is a trial from 01, so it is done within the ACE-ARB era. So carvedilol is a mortality play, even in advanced class heart failure. And then lastly, mineralocorticoid receptor antagonism is also a mortality play in class 3 and 4 heart failure with reductions of mortality across 2 years. So we have to use a RAS drug, we've got to use a beta blocker, we've got to use an MRA, and you should be looking to make sure the patient on all of those. And why? Because they reduce mortality. And the higher the class of heart failure, the more likely they get a mortality reduction. So what drugs do you choose? And this is an exercise I call same or different, and in the guideline-directed medical therapy. And this is as it relates to these older therapies. First is, what about an ACE or an ARB? Patients still take ACEs quite often, but Would you just not use an ARB and get to the same point? And the answer is basically that they are the same. A study called VALHEFT randomized patients to valsartan, captopril, or the combination. You know, valsartan, as you know, is an angiotensin receptor antagonist. ACEs, as you know, inhibit the conversion of angiotensin 1 to 2, and thus angiotensin 2 levels decrease. But what happens over time on an angiotensin converting enzyme inhibitor is that angiotensin levels gradually, 2 levels gradually go back up, because there's this thing called ACE release. There's other enzyme systems that actually produce angiotensin 2 that are not angiotensin converting enzyme. So that's where the rationale comes up that maybe both would be superior. Well, in the VALHEFT trial, in which it was one, the other, or both, there was in fact no difference in outcomes. There was, as you can imagine, excess risk with a combination because of hypotension, and side effects were worse with ACE inhibitors because of cough. And so the verdict of this is, from an outcome standpoint, they're the same. ARBs offer better tolerability, and for that reason, I think ARBs are really the starting point for RAS inhibition in 2021. How about your beta blocker choice? I see a lot of people still take metoprolol. There was an important trial called the COMET trial. It was the carvedilol or metoprolol European trial, and we randomized patients in metoprolol 50 BID and the short-acting tartrate salt or carvedilol 25 BID, and basically showed that carvedilol reduced the risk of death compared to metoprolol. Adverse effects were similar. So what's going on here? Why would carvedilol be better? Well, metoprolol, as you know, is a cardioselective beta blocker. It only inhibits it inhibits beta. It's a beta 1 selective beta blocker. Carvedilol has beta 1, beta 2, and alpha activity. And one thing unique happens in the failing heart. In your heart right now, you have more beta 1 receptors than beta 2 receptors. But in the failing heart, there's two changes. The first is that there's receptor downregulation overall because of high sympathetic tone leading to receptor downregulation. But there's also a shift where beta 2 receptors actually predominate over beta 1. So the failing heart both has fewer receptors and a shift in subtype, such that a mixed beta blocker, a beta 1, beta 2, and alpha blocker, is superior. So carvedilol is your heart failure beta blocker. Metoprolol is reasonable. Certainly, there are trials that demonstrate metoprolol is effective compared to placebo, but in a head-to-head fashion, carvedilol is superior. And lastly, diuretics. I mentioned diuretics. The diuretics aren't mandatory if people don't have problems with volume and sodium. But what diuretic do you use? And there are two types of diuretics, right? There's potassium wasting and sparing diuretics. The potassium sparing diuretics are one of a couple of types. Mineralocorticoid receptor antagonists sort of fit into that genre. And a study called the SOLVE study, a study of left ventricular dysfunction. There was a series of studies in the SOLVE trial series that looked at outcomes relative to diuretic type. And you see here in this table, compared to patients with no diuretics, those who received any diuretic had worse outcomes. Okay, so there's a point for you that it's really any diuretic is worse than no diuretic. And this is a propensity matched analysis, so that one would think that, so diuretics may have, although they make people feel better, they do other things, such as they activate the sympathetic nervous system. But in this analysis, it was the non-potassium sparing diuretics where the risk was observed. That is the loop diuretics. So we use loop diuretics in the hospital because they decongest patients, but a loop diuretic is not a necessary part of a patient's long-term management strategy if they can manage volume and sodium with other means. And they're also, and you can also use non-potassium wasting diuretics, that is the potassium sparing diuretics, as an alternative. So the verdict here is these are different, and we want to certainly use MRAs as the base and then loop diuretics sparingly. So then just this year, and just recently came out this 2021 heart failure update, and I want to take you through this algorithm, and we're going to use this as a jumping off point to talk about optimal use of diuretics, optimal use of SGLT2s and ARNIs. So if we start with the heart failure stage C patient, it first begins with ARNI, ACE, or ARB. And you see here in the green box, ARNI is preferred. ARNI is preferred, and then using an evidence-based beta blocker. And for me, that would be carvedilol. And then you have other options seen in these other in these boxes. And starting with the left, for patients with a GFR over 30, creatinine less than 2.5, then one should add an aldosterone antagonist. As long as the creatinine's over, it says 2.5 in males, 2 in females. I use 2 as a practical cutoff. So a mineralocorticoid receptor antagonist. So the second box then, it is for patients meeting GFR criteria, you should add an SGLT2 inhibitor. And your GFR has to be over 20 to use empagliflozin. Pretty liberal criterion. So GFR down to 20 is where the data extends for empagliflozin. For patients with persistent volume load in the center box there, it's titrating diuretics. And then for persistently symptomatic Black patients, despite RAS inhibition, et cetera, Bidil is an appropriate choice. So what you're seeing is the elevation of ARNIs and SGLT2s into the early treatments of heart failure to reduce ejection fraction. So I have 3 tips for you. I'm going to take you through each of these. The first in heart failure is to use diuretics wisely. So diuretics exist in a variety of forms. There's loop diuretics. The loop diuretics are actually secreted, are actually secreted into the proximal tubule. It is then, where do they act? They act in the loop of Henle to inhibit about 1/4 of sodium reabsorption. The thiazide diuretics, as you see in the top right, act in the distal collecting tubule to inhibit about 5% of sodium reabsorption. And then the in terms of aquapheresis drugs, such as the Vaptans, tolvaptan, they act in the collecting duct to inhibit the reabsorption of free water. The other thing to watch for is SGLT2 inhibitors, which also act in the proximal convoluted tubule where glucose and sodium are exchanged. So there's a reason. This sets up the notion that a loop diuretic has to be secreted first, so it needs good blood flow and adequate perfusion of the kidney to get there. It then has to reach the loop of Henle to inhibit sodium reabsorption, and over time there actually can be hypertrophy of that, and that can cause diuretic resistance. One of the key lessons about diuretics is in the bottom center in that table. Loop diuretics are not all the same. Furosemide has an oral bioavailability which is between 10 and 100%, and has a relatively short half-life, elimination half-life, as does bumetanide. The difference, though, is that Bumex, bumetanide, and torsemide have much higher oral bioavailability, 80 to 100%. So furosemide is your least bioavailable and your most variable bioavailable diuretic, which is why often in patients that don't respond to furosemide, choosing bumetanide or torsemide is an alternative. Now, other than this feature, do you favor one over the other? Not necessarily. I would say that torsemide is a longer acting diuretic. You can see that patients with congestive heart failure, the half-life of torsemide is up to 2 to 4 times longer. So torsemide is a longer acting diuretic with good oral bioavailability. The key thing is that with diuretic doses, there is no right dose. You see in the bottom right there, you see that compared to the normal patient in the blue line, whereas diuretic concentration increases, the fractional excretion of sodium increases until you get to a maximum, whereby further diuretic dose does not lead to further fractional excretion of sodium. That defines there's a threshold and then a maximum. The threshold is where you start to get onset, and the maximum is where you cease getting any further. In heart failure, you have 2 things happen. First, the threshold is increased. The curve is shifted to the right. And so to higher doses of diuretics are required to see the same diuretic effect. And lastly, they have diminished maximal diuretic responsiveness. So heart failure patients require higher doses of diuretics, and even at those doses, they get a diminished responsiveness, which is why we have to think about using diuretics differently. I think what we commonly see in the hospital is people get the standard 40-40, you know, of Lasix or furosemide, and then we don't see rapid decongestion. The whole goal of a hospitalization in heart failure is to rapidly decongest the patient. And this is the European Society of Cardiology guideline from 2019 that actually describes how to use a diuretic. And I want to walk you through this. So the left panel is the first 24 hours, and the right panel is the second 24 hours of a hospital stay. In the first 24 hours, in a patient who starts with congestion with volume overload, the question is, are they loop diuretic naive? If the answer is yes, then the starting dose of diuretic is 20 to 40 milligrams intravenously. If the answer is no, you typically double the 24-hour oral home dose and you give it intravenously. So if they're on 40 BID, you give them 160 milligrams IV. Again, you double the 24-hour oral home dose and you give it intravenously. So that is different than we typically see in the hospital. The next thing is that you do this, and then in 6 hours, either in 2 hours, you get a spot urine for urinary sodium to show that it's over 50 to 70 milliequivalents per liter. Or you can simply look at the average urine output, and it should be at least 100 to 150 mils an hour. I think often what we do is we give a diuretic, and when they come back the next day and see how much did they put out. What you want to do is use 6-hour increments, because remember, the half-life of furosemide is only 1.5 to 2 hours. Maximum 3. So at 6 hours, you know what you're going to get. What you then do is if they achieve that rate of urine output, you just basically continue that same loop diuretic dose every 12 hours. So 160 Q12. Or if they haven't achieved adequate urine output, you double the dose. And then you reassess within 6 hours. And every 6 hours, you reassess and increase the dose to get the onset, to get to threshold where diuresis starts, so you can push them to maximum. And the goal is to get 3 to 4 liters of urine output per day. 3 to 4 liters of urine output per day. So I think we often underdose diuretics. We don't assess them early enough for adequacy of urine output, and we don't escalate fast enough. Now, what about on the second day of admission to the right, if the patient has persistent congestion? This is where if they're on the right side, if they have urine output of 3 to 4 liters, you're basically continuing diuretics. On the left side, the urine output is submaximal. You're going to, again, max the dose of diuretic. And then if that fails, that's when you're going to add a second agent. So in the second day of hospitalization, if you're not getting in that Q6 hour reevaluation, you're not getting 100 to 150 an hour of urine, you're going to add typically a thiazide diuretic. Why? Because that acts in the distal collecting tubule to inhibit additional sodium reabsorption, to augment the diuresis of that Lupa-Henle effect of the loop diuretic. If that fails, in other words, you've added max diuretic, you've added a thiazide, not enough is happening, that's when you'll think about ultrafiltration as a bailout. But that is all within the first 48 hours of the hospital stay. And that's a way we can shorten the hospitalization and get patients better more quickly. How do you use diuretics? Do you use them bolus? Do you use high dose? Do you continuous infusion? I think this question is largely answered in that it's more about getting that rapid reassessment and getting the action and using bolus diuretics to get that high urine flow, as opposed to using continuous infusions. And what this was a 2x2 factorial design study of low dose versus high dose and bolus versus continuous infusion. In the top right, and you see the results that bolus is similar to continuous infusion. High dose is a little bit better than low dose. Really, the difference between the high dose and low dose is in fluid loss, more fluid loss with the high dose. Not really much difference between bolus and continuous infusion and fluid loss. So use bolus diuretics, and you give a bolus because you want to get that threshold met and achieve maximum quickly. And then you redose at 6 hours. And that obviates the need. If you redose, it obviates the need for continuous infusion. and it matches the pharmacokinetics of loop diuretics. I used to say that diuretics, in fact, had no evidence that they improved outcomes, because in fact they have never been tested in a randomized trial of outpatient care, which is really stunning if you think about it. There was a recent analysis, though, and this is actually done by one of the residents in our system, who they examined. This is through the VA collaboration. They looked at people who were older and had been discharged with or without loop diuretics. Loop diuretics were shown there in the blue line. And all-cause mortality and heart failure readmission was lower in patients that in the first, at discharge, they were prescribed a loop diuretic. So to me, this is interesting because while we want to use other guideline-directed medical therapy, early use of loop diuretics in these patients may improve their outcomes. So I don't have any problem discharging somebody on a loop diuretic that needs it after a hospitalization for decompensated heart failure. It's an outcome. It may improve their outcomes. This is not a randomized trial, but it's the best we have. And I think it would be typical that you would discharge someone on a loop diuretic, but it's in the ongoing care that you assess if they need it, and withdrawing it once they're on otherwise GDMT and have good dietary control of volume and sodium. Well, what about UF? And I don't want to go too deep into this, but patients get diuretic resistance, and they get diuretic resistance for a variety of reasons. There's a braking phenomenon. They get distal tubule adaptation to diuretic doses and hypertrophy. And they often have proteinuria, which also inhibits the diuretic use. And as they get hypotonic urine, there's reduced free water clearance, and then they start to get hyponatremic, and you're in this loop of not diuresing, getting more hyponatremic, and you need some sort of a rescue phenomenon. I think that rescue phenomenon is ultrafiltration, a simple hemofilter that runs a concentration gradient for solute to remove ultrafiltrate, which is basically isotonic to plasma in order to remove volume in an isotonic kind of way. The advantages of ultrafiltration are, unlike diuretics, it doesn't directly cause neurohormonal activation. It removes this isotonic plasma water. You can precisely dial in the rate that you're going to pull, and it gives people a chance to have a diuretic holiday to improve diuretic responsiveness. And it typically doesn't affect electrolytes, potassium, magnesium. So it has some advantages in the hospitalized patient. I would say to you, though, it doesn't change. The data is mixed on what it overall does, though. The graphs at the bottom are from this UNLOAD trial, and there's a lot of trials in this, and I picked this one because it favors, but there's data I can show you that don't favor ultrafiltration. So I think you use ultrafiltration carefully. But again, in that algorithm at day 2 on the ESC, if you're not diuresing and you've done max dose diuretics and thiazide, that's when you say, hey, it's been 2 days, I need UF. If you approach it that way, in the bottom left, ultrafiltration patients lose more weight. They don't have any difference in the change in creatinine in the center graph, and they do tend to have lower rates of rehospitalization in the right graph. So it is a way to diurese people, and if you use it in a diuretic-resistant patient that's failed escalation of diuretics and addition of thiazides, you will get more weight loss. It's neutral from a creatinine standpoint, and there may be reductions in rehospitalization rates. Why? Because they're better decongested. The last tip on using diuretics wisely is I'm going to suggest to you all that you use serial BNP. I don't know how many BNP we think about as a diagnostic test for, are they, is this heart failure dyspnea or is this respiratory dyspnea? I would say that BNP can also be used as a serial biomarker. It's really your troponin equivalent of heart failure. What we know is that if BNP is up and stays up, that's a patient that's going to do poorly. If BNP is up and comes down, that's a patient that you've decongested. Why? Because BNP is released directly in proportion to left ventricular and diastolic pressure. So when you decongest a patient and LV-EDP comes down appropriately, BNP drops. It's released in response to end diastolic pressure and ventricular stretch. So in this left graph, you see this is the patients in the solid bar, in the solid line are people who have an increase greater than 30% of their BNP. And in the dash line, patients who have a decrease in their BNP of more than or equal to 30%. So a decline in BNP is a sign of success in heart failure, and it would indicate lower likelihood of rehospitalization free survival, or greater likelihood of hospitalization free survival. In the right graph, you can see in the top line there is people, this is 30-day all-cause readmission, and according to discharge BNP. And the higher the discharge BNP, the more likely they're readmitted. And those readmissions are really for heart failure. You see in the light dash line. You can get heart failure-related readmissions down to 5% if BNPs are below 400. So I want you to serially measure BNP. You think somebody's improving, they feel better, they look better, recheck a BNP. Confirm that it matches your clinical suspicion. Find those people whom BNP is still up, hit them harder. Find those people that BNP's dropped a lot, get them home. Tip 2, use rnas as first line. So I don't know how many of you have prescribed an angiotensin receptor neprilysin inhibitor, but these drugs have been around now for 7 years in practice. They are the combination of an aldosterone, an AT1 receptor antagonist, an ARB, and that ARB is valsartan in the top. And then they are also, a second drug is added, which is sacubitril. Sacubitril is a drug, small molecule drug that inhibits neprilysin. Neprilysin is the enzyme that breaks down natriuretic peptides, including BNP. And so done, when vasoactive peptide levels are lower, a patient's vasodilate, their blood pressure is a little lower, sympathetic tone drops, they natriurease. It was in 2014 that the Paradigm HF study in the bottom left there showed that sacubitril valsartan, that is this LCZ696, that was the study drug number, was superior to enalapril for mortality. This is mortality rate in heart failure. So it's a mortality play against ACE inhibitors. Again, it's an ARB plus a second drug. Now, this led everyone to say, well, that's great, and they can do that as an outpatient. And I'm here to say today that I really want to be focusing doing this in inpatients. And here's the reason why. It comes on the right side in a study released about a year ago called Pioneer HF. So Pioneer HF was a study in which patients were currently hospitalized for acute decompensated heart failure. They'd been in the hospital for anywhere from a day to 10 days. They had a stable blood pressure of at least 100, and you weren't titrating, intensifying diuretics. They were not inotropes. Their EF was at least below 40. And they were randomized to enalapril or sacubitril valsartan. And enalapril is basically lisinopril. Lisinopril is a prodrug of enalapril. And you see here that there's in the curve in the top left, in terms of death, heart failure, rehospitalization, and proceeding to LVAD or transplant listing, early payoff within the first 2 to 4 weeks of reductions in event rates that grow across the first 60 days, such that at 60 days, there's a 46% reduction in the rate of death, rehospitalization, or needing to go to LVAD or transplant. And this is compared to enalapril. So these days, and this is hospital administration, most rehospitalizations occur quickly in the first month. And so this is a hospital-based therapy now. When patients come in the hospital, you have to be prepared to shift their drug. So there's a few tips here. The first is you can't go straight from an ACE to an ARNI because there's a risk for angioedema. You've got to stop the ACE inhibitor for 36 hours, and then you can start an ARNI. So my tip here is when patients get admitted and they're on lisinopril and they've got decompensated heart failure, put them onto losartan. That lets the ACE inhibitor start washing out. And then 2 days later, you can begin the sacubitril valsartan, which the starting dose is this 26-24, this 50 milligram tablet of sacubitril valsartan, and then there's up titration subsequently as an outpatient. There really aren't major safety signals compared in the hospital-based administration in terms of renal function, hyperkalemia, hypotension, or angioedema events. In fact, there's fewer angioedema events with sacubitril/valsartan than there are with enalapril. So this is an evidence-based therapy now with early payoff for outcomes compared to standard therapy of ACE. And really want you to think about hospital-based administration. Again, remember, you got to wash out an ACE if they're on it for 36 hours. Otherwise, you're good to go. Now, how about SGLT2s? So these are diabetic drugs, which have now become heart failure drugs and have now become cardiovascular drugs. They work in the proximal convoluted tube, in the proximal tubule to, again, inhibit the sodium glucose co-transporter, increase urinary glucose, and take water with it. But they do this without neurohormonal activation, which I think is the trick. Diuretics activate the neurohormonal system. This, for whatever reason, does not. And they were first tested for diabetes as diabetes drugs because they lower A1C about 0.5. And what they found is that, is that there was a significant reduction in cardiovascular death and hospitalization for heart failure with a very early payoff. You see the benefits are rapid. They actually begin in the hospital in terms of patients with events and extend into the early weeks and months post-hospitalization. So this is an early payoff drug for heart failure outcomes. What's been recently described last fall was, in fact, renal outcomes are also superior with these drugs. And from Coreg, they published in New England Journal in October the composite renal outcomes, that there was a reduced rate of proceeding to advanced stage renal failure, dialysis, and having death or adverse outcomes due to renal failure in the empagliflozin group. So it's not just a heart failure mortality, cardiovascular mortality play, but it's also a renal play to begin using SGLT2s. Again, empagliflozin 10 is your formulary drug. The good news here is there's no need to titrate. 10 is equal to the 25 dose when it comes to outcomes. The creatinine clearance can go all the way down to 20. And when you do this, and this is a tip, is to use it at the back end of the hospitalization, there's a slight risk for diabetic euglycemic ketoacidosis, and we want to avoid that. So if someone comes in decompensated, the time to add empagliflozin is at the back end of the hospitalization when things are good, they're stabilized, and you're getting them prepared in the last couple of days to go home. A couple more trials on SGLT2s that show this is now expanding. Emperor Reduce was a study published last year of class 2 to 4 heart failure with reduced EF, and you didn't have to have diabetes to get the drug. And it showed reductions of 5% absolute risk reduction for death and heart failure hospitalization, superior renal outcomes, just like Empereg. But the results were similar in those patients with and without diabetes. So indeed, this drug is now emerging, these drugs are now emerging as standard therapy for heart failure, irrespective of the presence or absence of diabetes. Dapagliflozin is an alternative, and it has basically similar data to empagliflozin, with now that from the declared TIMI 48 or TIMI 58 studies, some data starting to emerge in HFpEF. Heretofore, we've been talking about heart failure with reduced EF. The next horizon is heart failure with preserved EF, and there's early trending data that heart failure preserved EF benefits from SGLT2s as well, which would be a huge thing because heretofore we have very little for HFpEF. There's ongoing studies to further evaluate SGLT2s in HFpEF, and so there's more to come. But for now, whether it's heart failure, known heart failure, just simply reduced EF, or declared TIMI 58 was in patients with diabetes simply at risk for ASCVD, again, did not require heart failure, improved events. So this is now standard therapy for all patients with diabetes at risk for ASCVD, because it reduces the risk for cardiovascular death, hospitalization for heart failure. All patients with heart failure, irrespective of presence or absence of diabetes. So there it is. All patients with heart failure, regardless of diabetes, should receive an SGLT2. Safety is important. A few things to highlight. One is this risk for DKA, and the results are, the risk is very, very low, on the order of 1 in 1,000. And so it's uncommon, but that's why we don't give them to patients when they're ill, and we stop them when patients come in the hospital for other illness reasons. The patient comes in with acute cholecystitis, you hold their SGLT2. And the other is, I think as probably everybody knows, there's a small but meaningful risk of genitourinary infections, and that is something that you counsel patients on. Those can be both urinary tract infections as well. It's predominantly, though, in the slight excess risk is seen mostly in genital infections, not so much UTIs. So a couple of pearls. It's certainly in patients with diabetes, but now actually expanding to just heart failure in general and ASCVD risk in diabetics. Patients should be stable and eubulemic, and EF should be low at the current time, but that's expanding. And avoid use when they're acute illness. Hold pre-op 3 days prior to surgery. Again, creatinine clearance has to be above 20 for EMPA. And there is, if people have active critical limb ischemia, it's also not a time to start these drugs. So for a few months now, we've been running a heart failure e-consult program in MedStar, looking at utilization of these drugs and making recommendations through e-consultation. You may have seen some of these on your patients. I want to point to some success there, which is that on the left is how often we've recommended and how often then SGLT2 inhibitors have been started at discharge. And of the patients we've recommended, about 34% are actually started. That's a good starting point. We'd like to get that number higher. So don't be afraid of SGLT2s. Get social work to make sure it's affordable. In most cases it is. There's no prior authorization for these drugs, but put them on in the hospital. The payoff for early returns for readmission is very high and very early. And the second is ARNIs, and we're doing better with ARNIs. About 53% on the right, 53% of people we recommend ARNIs get them. And remember, you've got to wash out the ACE, convert them. You can step them through an ARB, but then discharge them on an ARNI. And again, that's one where most patients don't have prior auths, but again, social work can help. So I will stop there, and thank you for your attention. We've got some time for questions, and again, I want to leave this for open discussion, guys, to give you a chance to ask any questions you have, whatever is on top of your mind.
Dr. Taylor, thank you so much. There is one in the chat, actually. Maybe we'll start with there.
Oh, okay, yeah, I'm looking at my slides. What's that one say?
It says, do you recommend getting repeat BNPs even if you know someone is adequately diuresing by urine output?
Yes.
Yes, okay.
Because do you check a sodium every day? Do you check a CBC every day? Yes, and it's useless. Okay, so spend your money where it matters. No, I think why? Because even if they come in and it's high, A, you're confirming your clinical suspicion. That's great. You're training. You want to learn. You want to match your clinical suspicion, but also you've established a new baseline. That the next time they're back, they have a new baseline, that their discharge BNP was X. So I think it's reasonable to do. The one thing I would say, and being thoughtful about this, is there's you can say, well, gosh, don't ARNIs inhibit neprilysin, and isn't BNP the substrate for neprilysin? And there is, when you start an ARNI, some people's BNPs go up. Some people's BNPs don't change, and some people's BNPs go down. So it's a complex interaction between how quickly the patient's improving in their heart failure and the ability and their concentrations of substrate, their concentrations of drug, and what happens to the BNP level. If you see the BNP go up and you've begun an ARNI and they look great, I would say, okay, well, that's not making sense, and maybe it's the ARNI. Okay, but the ARNIs, the BNPs are still predictive when ARNIs are used. And so our recommendation generally is to check the BNP. If it goes down, you're good to go. If it goes up, you've got a little bit of thinking to do. Is this the ARNI making it go up? Is the patient really better? But that effect is generally fairly modest. It happens over time. And so I would honor an in-hospital rise in BNP as a sign that the patient's not improving like you think they are. Remember placebo effect. If you have someone in the hospital, 30% are going to feel better just because you're just taking spreading love on them. And so I think use the BNP as a biomarker of success.
Great. Thank you. There's another chat question. I've heard you can expect serum creatinine to rise with initiation of diuretics, and that is normal. But how do you approach it when patient continues to have an uptrending creatinine and not being adequately decongested?
Yeah, that's a great question. It's a common scenario, right? So certainly when you start an ACE, ARB, ARNI, creatinine goes up a little bit, right? Because you're not filtering as much. You've vasodilated the arterioles of the kidney, and so there's not as much filtration happening. You got to expect that one. When the creatinine's going up and they're diuresing, you have to think this is cardiorenal physiology, okay? And so you diagnose cardiorenal physiology. That is, there's an interaction between cardiac output, venous filling pressures, and intrarenal hemodynamics that is somehow not working in the favor of the patient's creatinine. Assuming that they're not post-renally obstructed, doing critical thinking, that they're not going to have post-renal obstruction, that there's not an intrarenal process that we're missing, just some other intercurrent illness with an intrarenal abnormality, and then it's all pre-renal. I think that is when I would think about getting, cardiology involved. Think about a right heart cath, because what you want to know there is what's their cardiac index, what are their right-sided filling pressures. Sometimes their filling pressures are lower than you think clinically, and you were fooled. And sometimes their index is lower than we think, and we're advised then to use inotropes to get them stabilized. So that's a case where we often use a right heart cath to resolve the confusion of what filling pressures are, what output actually is. But don't forget to think rigorously about the change in creatinine, as I know you will. Just there's other causes of rising creatinine than just heart failure. Good question. Let me ask you all a question. How, I should have put up the little polls, but let's do some discussion. We have a bunch of people on the line. How many people have, how can we do this? Everyone can go off mute, actually, and we'll say, tell us, have everybody say, are you using SGLT2s and ARNIs? And, this isn't, we don't know who, just, do you feel comfortable doing this now? And are you ready to do this? And what would hold us back to doing this as a team?
Hey, I'm Zema. I'm one of the residents on 2 North. We are using ARNI. I actually have a heart failure exacerbation patient right now, and we're using an ARNI on him. I don't think that we would start a SGLT2 inhibitor on him because his EF is greater than 40%. I actually did not know about that cutoff, so that's good to know. Thank you for that. But I feel like I would be comfortable starting it inpatient as well.
Yeah, good. Yeah, I think they're remarkable drugs for improving patients how they feel and relieving heart failure. We're not quite there with definitive data on HFpEF. I will say that from an ARNI standpoint, if your patient has EF sort of in that 40 to 45 to 50% range, we're calling that now heart failure with mid-range EF. So you guys have gotten so comfortable with HFrEF and HFpEF, we've got to keep it confusing. So we've got to create a third new category and call it heart failure with mid-range EF. And that's a group that's they're straddling the fence. And it was observed in some of the HFpEF trials that, for instance, with ARNIs, that patients with mid-range EF do tend to benefit from ARNIs, where those with the fully normal ejection fractions in HFpEF, 60, 65% do not. So heart failure with mid-range EF is an ARNI-eligible population in the emerging literature. How about the VHC medical students? Are you guys, I'm going to call you guys out. Nice picture. Have you guys had it? Tell us your experience. Love to hear the medical student experience.
It's been great.
Hey guys, have you guys used any of these drugs?
We actually just started yesterday, so we haven't been using them so far.
Mm-hmm. And so far, what, you guys are third years?
Yes, 3 years.
So far in your third year, have you seen patients on them?
No.
Okay. Well, you will. It's coming. But today's a good chance to get exposed to them. To get exposed to them. I kind of liken it. You guys are the new breed. See, you guys are we don't have to unteach the lessons of ACE inhibitors and all that stuff. You can just go right to what's new. The ACE inhibitor, metoprolol, and spironolactone, that's sort of like your flip phone version these days of heart failure treatment. Nothing, it's good. It's a good start. Look, if we could get every patient on those, and then to take them faithfully, we'd be in a good spot. But we want to even get to a better spot. How about Pooja? Tell me, Pooja, what's going on in your world with SGLT2s?
I feel like ever since CCU, like 2 months ago, I've like noticed it happen a lot more. Even in clinic now, we've been more cognizant of trying to start people on SGLT2s. So I feel like I've come across it quite a bit for the past few months.
The time to think about it is the day they get admitted, because it can take some time to kind of organize around it, and you got to kind of strategize out of the ACE to the ARNI, and yeah, so that's great. So think about it early. Who's better, Bless 3 or Bless 5?
Whoever answers first.
Bless 5's off mute. They got the edge. Bless 3, maybe? Here comes Bless 3. There you go.
So we would like to use them, but our patients are all ESRD on dialysis, and so that is limiting us. And hypotensive as well. So
yeah, there are some practical limitations. So let's not be too we got to keep keep it real here. I'll just give you an idea though, and the idea here is that there's ACE ARB ARNI is not contraindicated in renal failure, and there's a widespread belief that, and there's data to suggest that we underutilize those drugs in renal failure, and particularly when they're on ESRD and they're on dialysis. You're not going to have any potassium issues. Yeah, when they're incipient dialysis, I think you're in a tough scenario there. Hemodynamics could be disturbed, potassium disturbed. But if you've got an ESRD on dialysis patient, they've got HFrEF, do think about it. Particularly if you got blood pressure to work with, talk to the nephrologist and see, because there haven't been randomized trials in those groups. There's just been, like database analyses, but suggest that those patients probably could benefit and they're underutilized. Great comment. There are some practical limitations here. Patients are complicated. It doesn't always work out. So for the medical students on the line, it's there's the textbook answer, and then there's there's what happens in real life, and sometimes they match up and sometimes they don't. Jaggers is the auditorium, right?
Yeah, it's
the conference room. Quiet there. What other than SGLT2s and ARNIs? What other questions have come up with heart failure? What's on top of your mind? What's the heart failure bugaboo?
Sorry, I just had a quick question about one of the slides that you had. It was the comparison between metoprolol tartrate and Coreg, and essentially that Coreg was better at decreased mortality, and that was against metoprolol tartrate. But any data with like succinate? Yeah,
that's a good question. So the criticisms of the COMET trial were in fact that it used metoprolol tartrate, and that wouldn't have been better if it had been metoprolol succinate, little longer acting drug, single day delivery, and that the target dose of 50 BID with metoprolol tartrate was a little bit lower than the target dose of the studies. So Merit HF was the metoprolol succinate trial. I think those criticisms are fairly answered by, if you look just in the COMET trial, that the achieved heart failures and the achieved blood pressures in the carvedilol versus the metoprolol group were identical. So it's about as far as we can go to say that the drugs were hemodynamically, at least from a blood pressure and heart rate standpoint, achieving the same endpoints, but the clinical endpoints were different. Just the practical thing about carvedilol is it's just dosed appropriately for heart failure. You start with 3.125, you go to 6.25, you go to 12.5, you go to 25. So it's a little bit easier as a clinician just to dose the right drug. The key thing is target doses are 25 BID, and so you don't want to stop just because they're on 3.125 and you've started it. That's a great starting point, but you want to titrate. So I tend to say look, I think metoprolol is a reasonable drug for blood pressure. It's a reasonable drug for ischemic heart disease. When you've got legit heart failure, though, I think it's carvedilol is your drug. And there's not a tolerability difference between the two, really. So, but the outcomes difference, and the metoprolol succinate, there's been no head-to-head trial against carvedilol, so it would be speculative to say that one was better than the other, or that the metoprolol succinate would be better than metoprolol tartrate was in COMET.